Thank you for listening to Depictions Media Radio.
Welcome to Policy and Rights, the show about government policy and human rights. Welcome back to Depictions Media Radio. I'm your host, Michael Clogs. And in this next segment, we're going to hear from Adrian Dix, and we're looking at back to the issue of healthcare again, and doctors and how they're going to get paid, and the questions coming up about the idea of private versus public healthcare and how that actually plays out in our everyday lives and what type of effects it has on the level of care that we can actually get. Should there be a multi-tier system, or should there just be one single public system? There's a lot of questions out there around healthcare, but bottom line is this, and this is how we might want to see it, and might want to, when it comes time for the votes and everything, make sure that we're voting so that healthcare is no longer an expense, but it becomes a right. That we get the help we need to stay healthy, not just above sick, but truly healthy, truly free of long-term medications and things like that, that we get the health care we need so that we're getting ahead of chronic diseases and things, so that we, and also along with that, making sure that because there are things that just happen, that we are supporting those people who need that long-term care, they need that long-term help. That we have a healthcare system that supports that, and it is a healthcare system that should be the same no matter where we go in our globe. So let's listen to what Adrian Dix has to say as when he answers questions about how doctors are going to get paid. As he answers questions about where government stands on public versus private healthcare systems, and where they stand on a multi-tiered system as the NDP moves forward as a government. So let's listen to Adrian Dix and what he actually had to say in the press conference talking about healthcare.
Good afternoon, everyone. It's good to see everyone here today. Thanks for joining us. I'm Adrian Dix. I'm BC's Minister of Health. I want to begin our event by respectfully and acknowledging the history, the customs, and the culture of the Musqueam, of the Squamish, of the Tsleil-Waututh First Nations, on whose traditional lands we meet today. I'd also like to thank and introduce to you Dr. Ramneek Dosanjh, the President of the Doctors of BC, for being with us today for this announcement. We're here to talk about primary care. People in BC are seeing and experiencing strains on our healthcare system, strains caused by the 2.5-year public health emergency that is COVID-19 and its effects, extreme weather events, the toxic drug supply, the changing demographics and needs of our province, and the people who live here. People are struggling to access a family doctor when they need care. family doctors are struggling to keep up with rising operational costs, an aging population, and the increasing complexity of patients' health needs. It's a situation that requires actions, and we're working with the doctors of BC to enact transformational, long-term changes to the way primary care is delivered in our province. It means actions to retain and attract more family doctors. It means action to ensure that British Columbians have access to high-quality primary care when they need it. It means action to work with doctors of BC, family doctors, and other partners to find and put in place the solutions that work for all. Working in close partnership, we are doing just that, finding solutions that will provide not only immediate relief, but solutions that will last into the future. It's critical, essential work, and it demands time and care if we're to get it right. Work is underway on a new compensation model, but we know that solutions and supports are needed now. So today, the Ministry of Health and the doctors of BC are delivering $118 million in interim funding to support clinics and family doctors right now. The $118 million in interim funding for family doctors throughout BC will help them ensure their patients have continued access to primary care services. This action will help stabilize our primary care system. It will ensure that family doctors can maintain their practices, and this action will ensure family doctors can care for their patients as we work together on long-term solutions that renew, build, and strengthen primary care in our province. Over 70% of all family doctors working in BC, that's approximately 4,580 family doctors, can access this funding. This action on interim funding is key, but does not stand alone. It is one part of a multi-phased approach to protect and improve BC's healthcare system in the short and longer term. Today's announcement is one of many solutions that we're working on together. Our collaboration with the doctors of BC will see us develop a new physician master agreement and compensation model for longitudinal family doctors, an agreement we will announce later this year. And as we work toward this solution, action is ongoing. Discussions are underway, and through this, general agreements have been made on key components of the new payment model. Agreements include compensation based on the time spent by family doctors in providing primary care services and patient encounters, as well as complexity and attachment. Action is underway in developing additional measures that support and improve patients' access to primary care. This includes recruitment and retention of healthcare providers, and it includes additional resources for increased training capacity. These actions are ongoing, and this progress is being made, and we will report on our achievements as they are ready to launch. Ensuring British Columbians get the ongoing primary care they need means supporting BC family doctors in the ways that help provide the quality care patients rely on. It's that work and working together on it that will make the difference that patients and their family doctors are counting on. And now it's my pleasure to introduce Dr. Ramneek Dosanjh, President of the Doctors of BC, to the podium.
Thank you kindly, Minister Dix. I also would like to acknowledge the land that which I'm speaking on, the unceded territories of the Coast Salish, Musqueam, and Tsleil-Waututh nations. BC's doctors care passionately about our patients. We want to ensure that nearly 1 million British Columbians without family doctors get the quality of care they need and deserve. Today's announcement is a first step to help family doctors keep their doors open for patients until we can develop and implement a new payment model. We've heard loud and clear from our doctors that this is a much needed step, that we cannot allow clinic closures to continue at the rate they have been. This funding gives us time over the next 4 months to finalize and implement new payment model that will help us to recruit and retain doctors into longitudinal family practice. A new payment model will address rising business costs and also recognize the value of family doctors in the primary care system. It will also acknowledge the time they spend with their patients and the complexity involved in providing this type of longitudinal care. I want to thank all of our doctors, my colleagues, who are continuing to provide this level of care for their patients at such a challenging time. I want to acknowledge, and my heart goes out to all those patients suffering for their needs, because everyone truly does deserve a family doctor. We have a lot of work ahead of us to achieve longer-term solutions to help the primary healthcare system in this province. But I do believe that we are one step closer into getting there. Thank you.
Thank you very much, Dr. Dosanjh. Family doctors are the foundation of our primary care system, and supporting family practice clinics is the core of the province's primary care strategy and the commitment it makes to patients. It's at the core of the primary care networks. We're building 59 of them across BC, with more to come. This interim funding will provide the immediate support and stability our family doctors and patients count on, and will ensure the continued delivery of care for people in BC. Working with Doctors of BC, family doctors, and other partners, we will build upon and strengthen primary care services for patients, taking the short and long-term actions required to ensure certainty and confidence. I'm now happy, and Dr. Dosanjh and I are happy to take your questions.
Thank you, Minister. A reminder for reporters on the phone to please press *1 to enter the queue. That's *1 to ask a question. Please also remember to take your phone off mute. You will not be audible until your name is called. For media in the room, please indicate if you have a question and wait to be called. There is a microphone available. Please stand at the microphone and make sure to provide your full name and outlet. Our first question today is in the room. We're going to Penny Daffles.
Hi, Minister, and hi, Doctor. I just want to start out with a question for a colleague. If someone's listening to the announcement right now, they don't have a family doctor, what does this announcement do to help them get one, and how does this help family doctors who are feeling really burnt out right now?
Well, it's one step in the process. One of the reasons I think family doctors feel burned out, to talk about the family doctors first, is the pressures in the system, including issues of overhead, right? So if you look in a general sense, you see that those pressures on the system are real, and they put existing practices in jeopardy in many cases. So what this is a first step to stabilize the system while we build a new compensation model designed to increase attachment and to provide better care to patients. So it's good to stabilize the system. That's necessary, and this money will do that effectively. Over the next 4 months, it provides $118 million, which is essentially, if you look at the numbers in general, it's in this range, $25,000, in some cases slightly more per doctor. So if you have a practice with 4 doctors in it, that would be $100,000, as an example. So this is an important announcement that stabilizes a system, that addresses a key question of overhead that has been raised by family doctors with us, and it impacts patients and citizens who are the patients of those family doctors today. So that's critical point one. It allows us a little bit of breathing space and support for family doctors. It also demonstrates our commitment to a new funding model, a new model for primary care that will be better for patients and encourage more people to be part of full-service family practices. So that's an important step, and it's a first step. And you'll see in the coming days and weeks many other steps to increase both the access to the number of primary care providers. You know, we've added well over 1,000 in our primary care networks in the province, and we'll be continuing to take those steps. But this is a necessary first step. It reflects the dozens and dozens of hours that we've been working with Doctors of BC in recent months to address some of these fundamental questions. I think it's fair to say that our primary care system, which developed over a long period of time, that model no longer meets the needs of patients and meets the needs of doctors. So this is a demonstration, tangible action right now that brings immediate relief to family practices, and that's good news for patients and for doctors.
Penny, did you have a follow-up?
I do, and this is a question for me. You've often expressed pride in BC's surgical renewal plan and catching up on postponed surgeries, but the latest research from the Canadian Centre for Policy Alternatives suggests that at least some of that is happening at the enrichment of private companies. So I'd like to know, how is that providing value for taxpayers?
Well, let me start because you're asking about the report we saw today. I think it's fair to say that the suggestion that we're silently supporting private health care is wildly inaccurate based on the facts that are publicly available and widely available online. And, you know, we would have been happy to provide accurate information had we been approached to do so. Just to put it in context, health authorities contracted in 2021 $27.2 million to private clinics. That's 0.23%. So quarter of 1% of the 11.8 billion health authorities reported spending in acute care in the same period. In 2020-21, there were 13,863 contracted surgeries. That's 4% of the total, so 1 out of every 25 surgeries. The report also refers to diagnostics, 296,211 MRI exams in 2021-22. That's an increase, an astounding increase, all in the public system, contrary to what the report says, of 120,000. It is a spectacular performance. In that time, we increased the net new 17 new MRI machines in the public system, while the number in the private sector, which are providing non-medically insured MRIs, went down. So I think the example of the last few years is we've dramatically increased the number of MRIs. And why did we do that? For the very reason I think the authors of the report are talking about, that if you allow people to go outside the system and then come back inside the system and get an MRI, that creates a sense of two-tier healthcare. So we've changed that. This is a radical change. We went from last in the country to close to the top of all the provinces in Canada. By investing in the public system, we purchased 3 private MRI companies. And the money we spent to purchase them is included in here as expenditure on private health care. I think it's fair to say that's not an accurate reflection. We've engaged in surgical renewal, 400 trained new surgical nurses, 100 new medical device technologists, a dramatic 84 measures to increase the capacity, not of the private system, but of the public system. This has been a period of remarkable increase in growth of the public system and public responses to surgery. I put patients first. I think the government puts patients first. We do a small number of surgeries in the private with private clinics. None of them are extra billed. They have to comply to have a contract with us with the Medicare Protection Act and the Canada Health Act. And that's a significant change from the period of the previous government. There's a discussion of False Creek Surgical Center, which is really the only substantial sort of allegation in the report. Well, people forget that we canceled their contract because they wouldn't follow the law. And then they were sold, they came back into compliance, and their contract was renewed. The first part of that story is not described here. Right? That's what we did. I think that's the right thing to do because you've got to put patients first. And I think if you're waiting for surgery, you want it to be publicly paid and you want it to be part of the public healthcare system, and that's what we do. The numbers that are used to describe diagnostic care, what can I say, 300,000 MRIs, not one private contract. Right? That's a public system that has dramatically increased. Public sector solutions, public solution to public issues. And ironically, it's recommendations made by organizations like the BC Centre for Policy Alternatives that we've systematically put in place. So I'm very proud. I mean, the real story is a dramatic increase in the delivery of those services. It's why we reduced surgical wait times in a pandemic. We weren't ideological about it, but our position is patients first, 1, and 2, that the best solutions are in the public system, and that's what we've been delivering.
For our next question, we're going to go to the phones. Rob Shaw from Czech, please go ahead.
Hi there.
I'm getting used to this check
specific
thing.
Amount. Yeah, thanks. The specific amount, 118 million, the 25,000 average for doctors. How was that amount settled on, and how sure are both of you that that's enough?
It was settled on and discussed during a summer of work I think when family doctors came, and Dr. Dosanjh was one of us to meet with us a number of months ago, we talked about some of these issues. So if you look at it in a broad sense, one of the concerns expressed is that if a doctor becomes a hospitalist in a hospital and doesn't pay costs, for example, overhead costs, then effectively they are paid significantly more than someone who is working in longitudinal family practice, in full-service family practice. And so what this does for this period is address that particular issue and ensures that our family doctors are assisted in these times while we deal with the new model of compensation that we're developing together. So I think, time always tells, but this is a significant investment, $118 million for a 4-month period to support our family doctors. I think it reflects the work we've done together, and I think it will provide some support as a first step as we work through these issues. So I think it reflects the work we've done and the effort that's been put in, and I want to acknowledge all of the work done by senior officials of the Ministry of Health, led by Deputy Minister Steve Brown, and all of the people working at the doctors of BC. But I think this reflects a very significant investment that will support family doctors on issues of overhead.
Did you have a follow-up?
Sure, and maybe could also hear from Dr. Dosanjh on that question as well. But the follow-up is, could you give us some examples of the operational business costs that this covers, and just can we make sure, does it include, could a doctor use it to compensate themselves within that $25,000? Could they up their own salary, or is it only for certain types of costs? And maybe you could outline what those are.
So first of all, and Dr. Dosanjh will talk about it, what this is per doctor $25,000. Because these operational costs exist, right? They exist for every doctor, and they are paid for generally through fee-for-service billings, right? So the net salary or the net compensation for a doctor is what they are compensated minus their operational costs that they're paying. So this is $25,000 effectively, and it will be slightly different for different doctors, but that's basically what it is per doctor to provide direct support in this period. So it reflects overhead, but it is essentially a direct payment that will go through clinics to all those doctors. So it's not a complicated proposal. The money's going to go out. It's going to be allocated. Doctors will there will be a process for doctors to apply, and if they do apply and they go through the process in September, the money will arrive in October.
Just to address your question, this funding, again, is a temporizing measure. It's an interim solution to help stop the bleeding. Our family doctors are finding it more and more difficult as the increasing costs of rising costs of business. And we know that most family doctors in their clinic, the operational cost is between 30 to 40% and sometimes higher. So this funding allocation is for the period between October 1st and January 31st. It's a way to keep those doors open and to have our patients not suffer and to not add to the nearly 1 million patients without a family doctor. And we have to recognize, as Ms. Dafflos said earlier about the burnout, about our physicians on the ground, we have to recognize in order for them to keep their doors open and to keep up with the business costs that this is a temporizing measure. But we are working on a new payment model, which is to incentivize more family doctors to be able to keep them, retain them in family medicine, as well as recruiting our new physicians to family medicine. We need to incentivize for all of the work that they've been doing and value the time that they spend with their patients and the complexity and the ability to provide this type of care. Any further questions?
Our next question is for Katie DeRosa, Vancouver Sun.
Hi there. Thanks for taking my question. What do you say to doctors who might say that their staff is so burned out that, having to apply for this grant is just one extra thing that they're, have on their plate? And again, considering $25,000 is sort of a small amount considering the high overhead costs, will this be enough to actually incentivize people to not leave the profession?
Katie, $118 million from now to January 31st, 2023 is not a small amount. It's a substantial contribution. Many doctors, if you're looking at a net overhead costs, if you have, as I say, a practice with, say, 8 doctors, that's $200,000 overhead for that period of time. So it's a significant contribution, I think, and it's been worked out together as part of the work that we're doing together to address these fundamental issues. So I think that the characterization of that is just not correct. This is a very significant contribution that has been developed, and a proposal is developed not just by us, but by us, meaning the Ministry of Health and the doctors of BC, to make things better in the short run as we do what we need to do, which is fundamental change, which includes a series of measures that aren't about compensation for family doctors, but also includes issues of how we compensate family doctors, a system that is BC's system, which hasn't changed in fundamentally. It has in some significant areas, in particular since 2017, for the better, but it hasn't changed fundamentally in a long time. So, I just don't agree with the characterization of $118 million as a small amount. It's a significant amount, and it contributes and it demonstrates as a first step the actions that we need to take together. The way it was developed demonstrates it. The fact of it demonstrates it. The size of it demonstrates our commitment and our view of the need to reform and to reinvigorate a system, make it truly a primary care system for the 21st century. And in that, the doctors of BC and the government are partners.
Katie, did you have a follow-up?
Yes, and with the negotiations around the fee-for-service, I mean, that's been going on since May. So can either Dr. Dosanjh or Minister Dix explain what's the holdup? Is there perhaps a stall, or is there disagreement, or why can't we have that agreement sooner, considering how dire this is?
Well, first of all, we're as you might be aware, have the Physicians Master Agreement, which is a specific negotiation, is one of many negotiations that are taking place, including public sector negotiations right now. This one involves us not just negotiating in a classic sense, but working together to deal with fundamental issues around compensation for doctors. I spoke to it, and Dr. Dosanjh has spoken to it in our preliminary comments. But what it means is transforming that system, and in the meantime, taking steps to assist patients and doctors right now. And that's what this is doing. And so I don't think it's taking a long time, quite the contrary. But we're taking the action necessary, working together to make sure that that happens. And you have to get it right. It's important to get it right because the consequences are high. But our commitment is demonstrated by both the size of this this action today and the way it was developed in partnership with the doctors of BC. I'm very proud of the work we're doing together, and it demonstrates, I think, to people that effort pays off for them as well.
Next question is for Richard Zussman, Global News. Please go ahead.
This is both for the Minister and Dr. Dosanjh. I know there's a lot of pressure on family doctors. This alleviates some of it. One of the other potential ideas on the table is handing over some prescription powers to pharmacists. Is that something that's being considered by the province as part of these more overarching changes that could be coming? And Dr. Dosanjh, would family doctors support the idea of handing over some of those prescription powers in order to have more time to see patients with more complex needs?
Well, I think what I would say is this is today a major step to stabilize our system of family practice that will help patients and help doctors. It's not the only step. Issues around scope of practice are very important, and obviously all of those issues are on the table. But today we're announcing this, and I'm sure we'll have more to say on those other issues. I mean, issues around scope of practice and team-based care in a general sense in the coming weeks. But I would say on this question today, this is an important step forward. But there will be other steps. We have to ensure that everyone in the healthcare system contributes to the maximum extent they can. we've built with doctors, with divisions of family practice, primary care networks across the province, added well over 1,000 new FTEs. A very significant number of those FTEs are pharmacists. A significant number of those FTEs are mental health and addictions professionals, and close to 200 of them incremental in that period. And because that is what family doctors and communities needed and proposed. And so we're going to continue to work on team-based care and building out team-based care and making sure everyone works to the full extent of their abilities, and that's what doctors are going to do. But, I would say, Richard, one announcement at a time.
Richard, do you want me to echo this sentiment? I do believe that we need to work alongside our pharmacists and, like Minister Dix said, to the scope of practice, as well as facilitating our team-based care. However, prescribing and giving other options at this time is not the way to do things. We have a crumbling foundation of our primary care system, and that is what we need to support. Robust support for those docs that are bleeding on the ground, those family docs that can't keep their clinic doors open because of the rising cost of business. That's imperative, but we do look for alternative solutions and leaning on all of our allied healthcare professionals to support the care that's done in the community. I think we need to acknowledge that our patients matter. Doctors are more concerned about our patients and their well-being, and the access and attachment for those patients in our family medicine clinics is of priority. This step in the funding is also a temporizing measure for the next 4 months to hold those clinics over while we are devising this new payment model, which within it will hopefully give more options and ability for family physicians to provide the type of care that they went to medical school for. They are the clinical experts in diagnosing and treating them, and we need to be able to create opportunity for them to be able to practice the way that they were always meant to practice. And that's with ample support from all of our allied healthcare professionals, but also bolstering support for our newly graduating physicians that are coming into the practice. I hope that answers your question.
Richard, did you have a follow-up?
I do, and it does answer the question. Thanks, Dr. Dosanjh. And this is for Minister Dix. Back to the report that Penny was asking about earlier. I know you disputed a bunch of the content in there. One of the things in the report shows, this is a question from a colleague, despite evidence that private clinics drain resources from the public sector and evidence from government auditors that at least 2 private clinics were double billing, why were contracts with those facilities renewed?
Well, and I think it was part of the answer earlier to Penny's question, but in the case of Falls Creek Surgical Center, which was the main focus, I guess, of what was being put forward, that's exactly what happened. We have asked every private clinic that performs surgeries, the 4% of surgeries that are done through private clinics, to follow the Medicare Protection Act and to sign this and to follow the Canada Health Act. And they've all agreed to do that. When Falls Creek Surgical Center initially didn't want to do that and wasn't following it, their contract was canceled. And that's exactly what we need to do. We've taken further action than that, though, which is to buy a couple of the surgical centers, because that has allowed the doctors and nurses and others working in those surgical centers as part of the public health care system to do more surgeries, which is what we want to do. But we're putting patients first. And that's why we have dramatically increased the public system through surgical renewal by putting in place the specific actions, 84 of them, in the public system to expand access to public services, to dramatically increase our capacity by training more anesthesiologists, for example, by putting in place a replacement, and it's been put in place, an alternate payment model for anesthesiologists, put in place in many parts of the province now, that's moved away, in their case, from fee-for-service. And on diagnostic care, I mean, it is just not accurate to say, when we've increased the number of public MRI exams, and that's even more with respect to CT scans, from 174,000 the last year of the Liberal government to almost 300,000 during a pandemic. This is an exceptional increase. And how have we done it? By dramatically adding the number of public MRI machines, by dramatically using the machines we have in a very significant way. So there's only one machine in the province that went 24/7 before. I think the number is now 9. We've got 18 MRI machines that operate 17 hours a day, 7 days a week. And the results are startling, and they're a success for the public system. And so, and to draw any other conclusion or do a report that talks about diagnostic care and MRI and not say, that the number of public MRIs has gone up dramatically, the number of private MRIs has gone down dramatically, and to say that that is the corporatization of healthcare is just not accurate. And, that we can always have a debate about these things, and people are allowed to have their point of view and opinion. But there isn't much substance to this, and the substance shows that this is the public healthcare system doing what it should do. On surgeries, we've gone in many important surgical categories, according to the Canadian Institute for Health Information, not from me, from near the bottom to at the top. Knee replacements and hip replacements and MRIs are in that category. And I think we should be very proud of that. And it wasn't me that did it. It was the doctors and nurses and health sciences professionals and healthcare workers who did that work and made it happen. I'm very proud of them. And the final thing I'd say is it's always patients first. It's always patients first. And the best way to serve patients is to build the public healthcare system. That's precisely what we did and what we've been doing and what we're going to continue to do. And so, I think that people may want to make a point, but I think, unfortunately, the evidence is overwhelmingly goes in another direction.
Our next question is for Graham Lutz, Glacier Media. Please go ahead.
Hi, Mr. Dix. With regard to the growth trajectory of these private surgeries or private clinic surgeries, you said 4%. Are you looking to flatline that growth? Do you want to bring that down to 0, or is there a place for these contracts in the future moving forward? And do you see further growth in them?
Well, you say 4% and talk about growth. We just purchased 2 of them, so the numbers will go down, and I expect them to go down. But look, when you're a patient waiting for care, waiting for a surgery, you want to get that surgery as soon as possible. I'm the Minister of Health, and I'm telling you, that's why we put in place 84 measures to increase surgeries during a pandemic and reduce the wait lists for surgery during a pandemic, which I have to say is an exceptional achievement of our surgeons, of our surgical nurses, of our medical office administrators who had a big part in that work, of the health sciences professionals who do pre- and post-surgery work with patients. It's an extraordinary success. And so that number is going down. But I think, and it's my conclusion, that having a small number of surgeries that increase our capacity, that as long as they follow and there's no extra billing and follow the Medicare Protection Act, I don't have any objection to that, and in fact we've continued that. But we think that incorporating that fully into the public system improves our capacity. We're going to do everything we can to get people the surgery they need when they need it. That's what we've been doing. But when you include the amount we pay to bring and to buy a private MRI and bring it into the public system as a private cost, in other words, that's making the system more public, but to suggest because we pay money for those things that it makes it more private is just, well, it's not the case, of course. And to suggest that the money, for example, that we might pay a radiologist through fee-for-service and then through health authorities, of course we're paying more radiologists. When you go from 174,000 to 296,000 MRI exams, you're paying more radiologists. So all that's good news, providing better service, and that's what we're going to continue to do. But indisputably, it's just beyond dispute, the system has become more public in the last 4 years. That's true. Now, the numbers used in the report are 2015 to 2021, I think, and so that provides some conflation of that. But the system's become more public. 296,000 MRI exams from 174,000, all without any MRI contracts in the private system. That's making the system more public. Purchasing MRI machines, that's making the system more public. Repatriating contracts in the hospital sector, that's making the system more public. All of these steps are the steps that organizations such as the CCPA have been asking us to do and what we've been doing. So I find it that there are still surgical contracts with private providers providing care to patients for free or not for additional costs in the system following the Medicare Protection Act. Well, that's not a bad thing for patients. That's a good thing for patients. But that number is smaller and will continue to get smaller. Why? Because we just purchased a couple of the bigger private clinics.
Graham, did you have a follow-up?
Yes. Thanks for that response. With regard to the False Creek extra billing, I just want to get a better understanding of how you regulate and penalize these companies. So the overall question is that a stiffing up penalty for you to cancel the contract and then it's sold and you say it comes back into compliance and then they get more contracts after that? Could it be that are you between a rock and a hard place where you need these clinics to alleviate the wait list and you can't blacklist them entirely for having broken the law before? Or do you think that it's suffice that they can simply break the law, come into compliance, and then just get new contracts?
Well, first of all, with respect to it's the obligation of everyone to follow the law. And the Medicare Protection Act gets enforced in BC and will be enforced in BC. And that's pretty straightforward. But, I want to say, first of all, the key is providing service to patients. Why did we dramatically increase the number of MRIs? Because people were waiting too long. That effectively what the Liberal Party was doing in BC was telling people you have to go private and then come back into the public system, advance in the wait list if you had the money to do that. And that was the largest share, if you will, of what you might call queue jumping that was taking place. So how do you deal with that? You don't deal with that simply by taking legal action against people. You deal with that by increasing the capacity of the public system, and we've done that on MRIs and CT and colonoscopies in an unprecedented way. And that's good news for patients. And that's what we've been about. And the success is breathtaking compared to other jurisdictions in the country and everywhere else. So that's the first thing. What happened with Falls Creek Surgical Center? Well, we did more than take action. We canceled the contract. And then the business was sold. And then they came back and said we can provide a certain number of surgeries in compliance with the Medicare Protection Act. And they signed the contract saying they'd be in compliance with the Medicare Protection Act. And there was a contract in place with a different owner of Falls Creek Surgical Center. And I don't think the people who received that surgery, which is a small share of surgery in the system, 0.23% of health authority acute care expenditures, 0.23%, right? Don't think that's a good thing. They went in, they were booked for surgery there. They didn't pay for that surgery. They got the care they needed, and that was important. But overwhelmingly, how have we done it? We've increased operating room times on the existing healthcare system. We've activated mothballed operating rooms. We increased hours. We did surgeries on the weekend. That's how we did it. And it wasn't me that did it. It was the surgeons and the nurses and everyone else. And so what happened with Falls Creek was they weren't following the law. They got the contract canceled. They eventually decided under new owners they were going to follow the law, and the contract was restored. And so that's pretty straightforward. In the case of the ones on Vancouver Island, they felt and we felt there was a real opportunity to increase surgeries if those clinics were purchased in the public system. So we did that, and we're going to do more surgeries there than ever before. It's often going to be the same surgeons that do them, but it's going to provide better access to care for people on Vancouver Island. I think that's all good news. But the direction is all one way. It's the most efficient way, which is an efficient, successful operating public system. You look at what we do in primary care. The primary care system is an insurance system. So many of the doctors in question, their practice is a corporation, right? But the patients aren't paying for care. It's an insurance system. They're supported for care, and that's part of the system that we have in Canada. And have done from the beginning of the Medicare system in Canada. But in short, what we've done is taken very strong action to support the public system, to enhance public surgeries, to enhance public diagnostics and imaging, and all of the evidence is one way. And the only way not to say that is, of course, to admit the evidence.
Our next question is from Maura Wetton, the Tyee. Please go ahead.
Hi, good afternoon. Thank you for taking my question. Minister, can you go into a bit more detail about the eligibility for this funding? How much of it is new, and what's the allocation based on? Is it attached patients, typical number of days in the week in the clinic? Just a little bit more on that, please.
It's people who are either through walk-in clinics or through longitudinal family practice providing care, and I gave you the numbers earlier on that, so that's 70% of family physicians in BC. So it's that eligibility is per doctor. It'll be paid through the clinics, and it's going to be paid in October.
Mara, did you have a follow-up?
I do, thank you. Has the Medical Services Commission completed its review of TELUS Health MyCare, and when will that report be made public?
Well, as you know, and there's the Medical Services Commission, and Dr. Dosanjh is on the commission, so I won't ask her to speak and answer this question. She's on the commission, and as are many other outstanding British Columbians. It's their job to assess and enforce the law. And so they do this in different ways. There was a case a number of weeks ago of a clinic in the Capital Regional District that was proposing to charge a fee, and they've withdrawn that now, and the commission engaged with them. In that case, it wasn't an investigation. They engaged with them, and that was the conclusion, right? In the case of TELUS Health, what the commission does. So what happened? TELUS Health, issues around TELUS Health were brought to my attention. I asked the Minister of Health, the commission, to review it, and they're doing that. And they don't just review it, though. So the process of review isn't them doing the review and sending me a report and me taking action. The process is them doing the review and then taking action. They're an independent body, and they will announce their decisions, not just their review, but their decisions in due course. And it won't be me announcing that, it'll be the commission.
We have time for one more question. Our final question today is for Ethan Sawyer, CBC. Please go ahead.
Hey, Minister. Thanks for taking my question. As you said, $118 million is a significant amount of money. I'm just wondering if you can clarify where these funds are coming from, and also if you can clarify a little around the 30% of doctors who aren't receiving funds. Why not make this money available to everyone?
Well, because some doctors, as you'll note, and if you've been following the issue, you know some doctors are paid direct salaries and aren't paying overhead. So this is, well, the doctors we're talking about are the doctors who are affected by that. So effectively what this does in this period is it makes the situation fairer. So that a doctor, say, who's working as a hospitalist in a hospital and is getting paid perhaps the same amount as the physician in the community, but is not paying overhead. That doctor, even though they're a family doctor in BC and providing family services, and we love them and we think they're doing great, they're not paying overhead right now. They're getting their full salary, and they'll continue to do that, and they'll be subject to the negotiations we have with the doctors in BC across the categories. So that's the case. These are the practicing physicians in the community who are affected by these challenges of overhead and these challenges of costs that I and Dr. Dosanjh have referred to, and they're the ones who need this, and they're the ones who will be getting the money. So that's the difference between the two.
Ethan, did you have a follow-up?
And I apologize. It's been a minute since I called into one of these. Is there any chance I can get that answer in French before I ask my follow-up?
Well, I'll try it in French when you add for the follow-up. So I'll save it for those people who love my long answers in French at the end of press conferences and use it as an opportunity to go off the air and go to commercial. I'll let them do that. So I'll do all the French at the end. How's that? That's a note to networks, note to stations. So ask your follow-up, and then I'll try and give it a shot in French.
For sure. So my question is also about today's report about the so-called corporatization of healthcare. Just wondering if you can clarify, particularly around the False Creek Clinic, when they fell out of compliance, were they still able to do business? And if so, what does it say that these private companies are able to continue seeing patients even if they aren't necessarily compliant with the Medicare Protection Act? And if I can get that answer in French as well.
First of all, a doctor doesn't have to be in the Medicare service plan to practice in BC. That's regulated by the college. So there's usually a very small number of doctors. Forget the number. There's a very small number who can practice, and they do entirely private services. For example, there are a significant number of doctors who perform exclusively cosmetic surgery, right? They're not applicants in the plan, and when you look at private medical care in the province, a lot of what we call private clinics are actually providing that service, which is is what it is. And so I don't know. That's the case. So if you're not in the medical services plan, or you're not getting a contract from the doctor, from the government, there are other sources of services. ICBC has its own set of plans. WorkSafe BC has its own set of plans, which are all public systems, and working for them is entirely compliant under the Canada Health Act, for example. So there's different alternatives there. But in this case, the action couldn't have been clearer, and it was, just for research purposes, on, I think, the front page of the Vancouver Sun. I may be wrong about that. We took action to deal with False Creek and essentially move on from their contract because they weren't in compliance. And when they came back into compliance, we agreed to provide them with a new contract. It's pretty straightforward. That a small number of providers, 4%, it will be significantly less this year of surgeries are contracted. They're all within the public healthcare system. The patients don't pay for them. They're integrated into our waitlist systems, and people get the care that they need. It's, of course, in all of those cases, they're all what we call day surgeries, frequently cataract surgeries or other surgeries, right? So that's the kind of surgeries we're talking about. So, we took the action. So what did we do? We dramatically increased the public system. We delivered massive increases in surgeries and in MRIs. We took 84 measures to increase public capacity in our surgical system, and we reduced, in a pandemic, the number of people on our wait lists. That's using the public system to deliver public services to people. In addition, we brought in measures, amendments to the regulations around the Medicare Protection Act that had long been left dormant in 2018. And we took action in these cases on these contracts to make sure that all of those who do contracting work with us are in compliance with the Medicare Protection Act. And so those are strong measures, and False Creek is an example of that. They were out of compliance, their contract got canceled, and you see that actually reflected, I think, in the numbers in the report.
And I think in French, Minister.
This show has been produced by Depictions Media. Please contact us at depictions.media for more information.